Hello, Brickface here from Audio Medical Basics, and will be our last book in the cycle that we mentioned. Then we'll see how we go around. I mentioned about this book, the Quick Answers to Medical Diagnosis and Treatment by Lange, McGraw, and Hill. I spoke about this book already, about how this book goes, as this book introduces itself, provides practical expert information on diagnosis and management when you just have a few minutes. It is a single source reference designed for quick and easy access to the information you need in the clinical setting. And structured alphabetically, present each topic with just the right amount of information to give you the key diagnostic and treatment features of more than 500 diseases. All right, and important disclaimer also in this book. I read this before, but I'll read it again.
Medicine is an ever-changing science. As new research and clinical experience broaden our knowledge, changes in treatment and drug therapy are required. The authors and the publisher of this work have checked with sources believed to be reliable in their efforts to provide information that is complete and generally in accord with the standards accepted at the time of publication. However, in view of the possibility of human error or changes in medical sciences, neither the authors nor the publisher nor any other party who has been involved in the preparation or publication of this work warrants that the information contained herein is in every respect accurate or complete. And they disclaim all responsibility for any errors or omissions or for the results obtained from the use of the information contained in this work. Readers are encouraged to confirm the information contained herein with other sources. For example, and in particular, readers are advised to check the product information sheet included in the package of each drug they plan to administer to be certain that the information contained in this work is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. This recommendation is of particular importance in connection with new or infrequently used drugs. Okay?
So it's very important to remember this. So we'll start today. We'll take one topic from this book. We'll start with the abdominal aortic aneurysm. Abdominal aortic aneurysm. So, key features, essentials of diagnosis. Most aortic aneurysms are asymptomatic until rupture, which is catastrophic. Aneurysms measuring 5 centimeters are palpable in 80% of patients. Back or abdominal pain with aneurysmal tenderness may precede rupture. There is hypotension and excruciating abdominal pain that radiates to the back. General considerations. The aorta of a healthy young man measures approximately 2 centimeters. An aneurysm is considered present when the aortic diameter exceeds 3 centimeters. Aneurysms rarely cause problems until diameter exceeds 5 centimeters. 90% of abdominal atherosclerotic aneurysms originate below the renal arteries. Aortic bifurcation is usually involved, and common iliac arteries are often involved. Demographics. Found in 2% of men over age 55, male to female ratio is 8 to 1. Next is clinical findings, so symptoms and signs of abdominal aortic aneurysms. Most asymptomatic aneurysms are discovered as incidental findings on ultrasound or CT imaging. So now symptomatic aneurysms. Mild to severe mid-abdominal pain due to aneurysmal expansion often radiates to lower back. Pain may be constant or intermittent, exacerbated by even gentle pressure on aneurysm sac, and may also accompany inflammatory aneurysms. Inflammatory aneurysms occur when an inflammatory peel surrounds the aneurysm and encases the retroperitoneal structures, which include the duodenum and occasionally the ureters. Okay, now about ruptured aneurysms. Ruptured aneurysms cause severe pain, palpable abdominal mass, hypotension. Free rupture into the peritoneal cavity is lethal. Most aneurysms have a thick lining of blood clot which can break away and occlude blood flow in a small peripheral artery, an embolism. Although this phenomena is rare, multiple localized areas of poor peripheral blood flow should prompt a search for an aneurysm. Multiple localized areas of poor peripheral blood flow is blue toe syndrome should prompt a search for an aneurysm. Diagnosis. Laboratory tests. Even with a contained rupture, there may be little change in routine laboratory findings. Hematocrit will be normal since there has been no opportunity for hemodilution. Aneurysms are associated with cardiopulmonary diseases of elderly male smokers, which include coronary artery disease, carotid disease, renal impairment, and emphysema. Preoperative testing may indicate the presence of these comorbid conditions. So next in diagnosis, imaging studies. Abdominal ultrasonography is the study of choice for initial diagnosis, is useful in screening 65 to 74-year-old men, but no women who have a history of smoking. Repeated screening does not appear to be needed. Okay, next, abdominal or back radiographs. Curvilinear calcifications outlining portions of aneurysm wall may be seen in approximately 75% of patients. Next, CT scans. CT scans provide a more reliable assessment of aneurysm diameter. They should be done when the aneurysm nears the diameter threshold for treatment. Then next, contrast-enhanced CT scans. These show the arteries above and below the aneurysm, and visualization of this vasculature is essential for planning repair. Treatment. Emergency repair. If the rupture and bleeding are confined to the retroperitoneum, both the low blood pressure and retroperitoneal containment may arrest blood loss long enough for the patient to undergo urgent operation. Endovascular repair represents the best opportunity for survival because the retroperitoneal blood clot is left intact. And we will speak about endovascular repair later. Patients who have free rupture of the aneurysm into the peritoneum do not survive long enough to undergo surgical repair. Elective repair, generally indicated for aortic aneurysms more than 5.5 centimeters in diameter, or aneurysms that have undergone rapid expansion, which is more than 5 millimeters in 6 months. Surgery. Surgery is not indicated when inflammatory aneurysm is present unless retroperitoneal structures such as the ureter are compressed. Interestingly, the inflammation that encases an inflammatory aneurysm recedes after either endovascular or surgical aneurysmal repair. Open surgical aneurysmal repair. So, in open surgical aneurysmal repair, graft is sutured to the non-dilated aorta above and below the aneurysm. This involves an abdominal incision, extensive dissection, and interruption of aortic blood flow. Mortality rate is low when the procedure is performed in good risk patients in experienced centers. Older, sicker patients may not tolerate cardiopulmonary stresses of the surgery. Okay, now about endovascular repair. Endovascular repair, stent graft is used to line the aorta and exclude the aneurysm. Anatomic requirements to securely achieve aneurysm exclusion vary according to performance characteristics of the specific stent graft device. In general, successful attachment requires a segment of non-dilated aorta, a neck, between the renal arteries and the aneurysm to be at least 15 millimeters in length. Device insertion requires iliac arteries to be at least 7 millimeters in diameter. Okay, so we'll finish there. And this is all for our case today from the quick answers to medical diagnosis and treatment book. We spoke about abdominal aortic aneurysm, and see you all inshallah in the next video. Please don't forget to share, like, subscribe, and share.